Hello, and welcome to the Total Cost of Care Affordability Improvement within the Triple Aim pre-recorded webinar. Today's webinar is presented by Dr. Howard Epstein, Chief Medical Officer and Executive Vice President of Preferred One Health Plans, and Dr. Gary Oftedal, former Chief Knowledge Officer of Institute for Clinical Systems Improvement, who will join Dr. Epstein for the Q&A portion of the webinar.
Part of what we were asked to do is to talk about the recently released total cost of care measure. And I guess I'd like to sort of maybe frame up the rest of this by talking about, a lot of this might be conjecture, hypothesis, what we think. But as you've outlined all this work that we've done in the past on addressing cost and beginning to sort of actually talk about it for the first time, we've had evidence through like RARE campaign, HTDI, of some of the impact. Knowing that in healthcare we oftentimes study to the test, we now have developed or released a total cost of care measure. So all healthcare providers are able to look at that. Now, I think we could talk all day about issues about how to develop. I'm not going to do that. Can you talk a bit about what, as you've done all this work on affordability, what do you see as the impact of now having a measure of total cost of care and how you see that being both used in a positive and maybe a challenging way by healthcare providers? Do you have thoughts on that?
I do. Yeah, it's a great question, Gary. I think the best way to explain this, or the way I see this, is that we're where we were in cost of care measurement, where we were 10 to 15 years ago in quality measurement. We argued about first that the methodology wasn't appropriate, and this is unfair to my population or to my practice, and that the data wasn't accurate. And then it became, well, the data might be accurate, but my patients are sicker. And then we had appropriate risk adjustment for quality, and then it was, well, okay, so my patients aren't that much sicker than everybody else's. Now you have objective measures, but what can I do? And I think that's where we're getting to, is what can I do to improve cost of care and affordability, the same way that we were 10 to 15 years ago about using quality measures to improve quality outcomes. So you probably know who said you can't improve what you can't measure.
Right.
That's where we were with quality,
Right.
And that's, I think, where we're getting to with cost of care. Now, let me explain that it wasn't that before Minnesota Community Measurement developed their cost of care measure that there was no way to measure this. Right. There certainly was. The healthcare providers know to a large extent, at least on the CFO knows where the money is being spent, what kind of revenues were coming in, what the utilization patterns of the services were. Health plans were measuring this from their perspective, and they not only were looking at revenue and expenses and utilization and managing those factors, but they started developing very sophisticated tools and measures for looking at total cost of care. Now, there are like other businesses out there, there's different ways to measure total cost of care. And what was happening was that different health plans and the government, of course, were developing different ways of measuring that total cost of care. We were starting to develop a cacophony of measures. Right. And so what Minnesota Community Measurement really did is come along and say, okay, let's not look at the apples and oranges and the bananas that were out there, but let's develop a set of apples that we can compare total cost of care and start to measure the efficiency and the affordability of procedures, testing, but also the overall cost of care over a period of time, usually a year, and for clinic systems, health systems, so that people can then have that information on cost, start to combine it with the quality measures that we've had in the past, along with developing satisfaction and experience, especially patient-reported outcomes measures, and really start to paint a more clear picture of patients' perspective of value of healthcare based on their needs and their preferences for healthcare. We're starting to develop that environment where purchasers and consumers can now make more informed decisions around healthcare value. We used to blame consumers for not making better choices and contributing to the healthcare an affordability problem. But how can you blame people when they don't have the information to make decisions?
Well, I must admit, as someone who recently as retiring, had to look into that, the information out there is so confusing, just to be mind-boggling. And I kept thinking that here I am a physician, and I was having trouble deciding to pick insurance. Do you see this as an opportunity to make this the information more relevant so that people can actually understand it? It seems like if information is useful, but if it's still presented in a manner that people don't really even understand how that impacts them, if they have no liability, responsibility, accountability for that, I mean, there are some pros and cons about how this intended and unintended consequences potentially down the road.
Well, there are. I think a couple of points there. One is we're just starting to take the first steps down this journey. I think a lot of the information is at the aggregate level, especially when we're talking about total cost of care. That's an average across a population. It's one of these population health measures. And we have to get more granular. New tools, new resources, new technological approaches are being developed, and we're getting increasingly sophisticated about our ability to drill down to more specific information that consumers can then use for themselves. Now, we already have a lot of information, and we're able to demonstrate unnecessary price variation, much in the way that we've been able to demonstrate unnecessary or unwarranted quality variation. And Elizabeth Rosenthal at the New York Times has done an amazing job of showing how not only different regions of the country or different cities within a particular state can have one test, like a colonoscopy, that could cost $6,000 in one provider office and $600 or $1,200 across town, but sometimes even in the same city, or even sometimes in the same building, you have two different providers, and you could walk across the hall and have thousands of dollars of variation, much in the way that you can be sitting on an airplane next to somebody where you paid $200 more than the person sitting next to you based on when you bought the ticket and who you went through and everything else. So that's number one. Number two is that there are already specific tests and procedures. I think community measurement lists about 100 of those, where you can go out and look at those price variations on standard tests and procedures. We're also getting towards a place, although I think it's an intermediate step, in moving from fee-for-service to pay-for-value or pay-for-outcome, where we're beginning to bundle services. And you can actually go, much in the way you can go to a retail health clinic like a CVS Minute Clinic or a Target Clinic, and know how much it costs. If I walk in, this is what it's going to cost if I have a strep test, or if I have an ear infection, how much it's going to cost to be evaluated for that. When we walk into a doctor's office or a hospital, we have no idea how much it's going to cost for an episode of care. So at least for some specific episodes of care, like joint replacements or maybe bypass surgery, we're starting to price individual episodes of care. It would be harder, although we're getting towards, again, that sophisticated methodology where we may be able to price other longer episodes of care, like a course of treatment for cancer or a year of diabetes care. But if it was easy to do that, everybody would have done it by now. We're still, again, just evolving our ability to do that.
So total cost of care measure, I'm not as informed maybe as I should be, but could be, really is addressing sort of the professional, facility, inpatient, outpatient, pharmacy, lab, radiology, behavioral health, ancillary costs within the healthcare system. So as we think about the impact of the social determinants of health on people's health, do you see the total cost of care measure as either an opportunity, a challenge, an obstacle, or maybe an opportunity for organizations to start thinking how they work and start linking to the community better? I mean, we've sort of isolated ourselves in healthcare systems, and yet from the graph you showed, 80% of what impacts my health or my well-being has a lot more to do with what's out in the world. Do you see this leading to different discussions going on with healthcare providers as they start addressing total cost of care?
Yeah, it's ironic, isn't it, Gary,
Yeah.
that we measure what we're able to measure.
Right.
It may not be the appropriate thing to measure, though.
Right.
So much as how we really focused on quality as a reflection of the healthcare delivery system, not the kind of health that we produce for our populations and our communities, we're looking at cost of care in much the same way right now, because it's what we can measure. It's where we have the data. But as we're having broader conversations about producing that triple aim of health, and we know that really to make a profound impact on health outcomes, improving the quality experience and the affordability of care, we need to take a broader definition of health. And so that I think that's the reason why CMS and the commercial population are starting to link the other social determinants of health with population health outcomes. First thing is developing measures around those. We have patient satisfaction scores through Press Ganey and NRC Picker, but those are very healthcare system focused, and it really doesn't paint what I call the experience of care. Plus, patients want to experience health not just in the healthcare delivery system; they want to experience health in their lives. And they don't want to, and they don't live in the clinic or the hospital. 99% of health is what happens outside the hospital in the four walls of your doctor's office. So in order to produce better health, we really do need to know how those other societal factors drive health. So measuring those is number one, and initiatives like Hennepin Health is one example of how the healthcare system is trying to work with their community to link those things as well. It's going to be very interesting what happens. I think the main barrier to that is not only the silos that you talked about, but also the baskets of money.
Right.
These come from different baskets. We have budgets for the hospital and the clinic. We have budgets for transportation. We have budgets for public health. We have budgets for education. As long as we look at these as financial silos as well, it's going to be very, very difficult to build a health system that really can drive overall population health. We need to start being creative in how we use all of that information available, create appropriate incentives for both the providers and the consumers of health and healthcare through all those different factors.
So it feels to me a bit like, and I think you mentioned this before, that we're at the stage of this now where we were with diabetes when we were just measuring, did you get a A1C done?
Mm-hmm.
Now we have the D5. Now there are people who could argue about the D5 overall, but it's led us into an area that 11 years ago or 12 years ago, you saw 3% of patients meeting the D5.
Mm-hmm.
Now you can see 40, 50, or 60%.
Mm-hmm.
I think that just reflects the fact that we're going to learn a lot. Do you see that same thing with, I think you mentioned with total cost of care? It may look different in 2 or 3 years than it does now. We start to understand more of the impact of this and moving forward.
I think that's a fair statement. So we have to start off with process measures often when what we really want is outcomes measures. We don't want to make sure that people got their A1C for the sake of getting more A1C tests. We want to make sure that they don't have more heart attacks and strokes or have to go on dialysis for their kidney failure or have their limbs amputated. That's the real outcome that you're looking to achieve. But we have to start somewhere. And now that we've developed and trained providers and healthcare delivery systems on how to do process measures and quality improvement, we can start to look a little bit forward towards those outcomes measures and now start to tie reimbursement or value-based purchasing with those outcomes measures. Not that those process measures are no longer important, but those are more internal factors that healthcare providers look at. Or as I've heard you say, Gary, and I tend to say a lot these days, is when you buy a watch, you don't want to know how the watch works. You just want to know what time it is.
Right.
People don't care how the healthcare happens.
Right.
They just want to be healthy. That's what we need to get towards.
Agreed. maybe one last question, just so we wrap this up. It was struck me, and as I read through the press release, that they actually came out that the average monthly cost is $435 per month, but there was a $1,500 gap between those in the middle of that. That seems like a tremendous opportunity for reducing unwanted variation among groups. I mean, it shouldn't be that much differentiation truly just because your patients are sicker. I mean, this should be built in.
Well, and this is risk-adjusted cost.
Exactly right.
So we've already accounted for
right.
how sick your population is.
Right.
Now, that's from a medical perspective. I think it's a fair statement that some providers and others argue that we haven't really taken in we just talked about, those societal factors for adjustment. So income and employment and transportation availability, access to health care. So there's more work to be done there. But again, as with the quality measurement 10 or 15 years ago, it's still directionally appropriate. What we do know, and there are very smart people at the University of Minnesota in the School of Public Health and so forth that have already shown that, there may be some slight differences in risk adjustment based on those societal factors, but it doesn't really change the overall results of how providers perform. Whether it's with respect to quality outcomes or the total cost of care measures. So there's still valuable information, even if it's maybe not admittedly 100% accurate. It's 90% of the way, and that's good enough to look at what could we be doing differently. How can we build a better mousetrap? Particularly, how do we take healthcare delivery from a site of care to what we do wherever the patient is, not where we make them come to the healthcare system to get their healthcare. We have to engage the entire community and engage patients no matter where they are in their lives to produce better health outcomes. So I think we're going to begin to explore this information, understand it. The price variation is certainly something that has many factors, not least of which is contracting with health payers. And there are certain healthcare providers and systems that, due to their size or geographic location, can command higher prices at the negotiating table. I'm not saying that's wrong. It just is. It's just a fact. And so, how do we use that information though to drive affordability improvement? Again, the same way that we used quality data to drive quality improvement over these years.
So I think what we've tried to do here is to have a little conversation about sort of the background of some of the total cost of care, some of the issues looking at that, begin to have a conversation on where it's going to go. We've got a long way to go yet. Having been in healthcare for over 40 years, I think it's amazing to even have these conversations. Many times when I was in practice, I really had no understanding or appreciation of the impact of what I was doing on the cost. I think that certainly it's about time we do that. It's not perfect yet, but I think we are now taking the first steps in that right direction. I think it will be imperative for all of us, whether we are in the payer standpoint, the provider standpoint, or the community standpoint, to think about getting out of these silos and working together on this, much like we've done already with readmissions and much as we're doing in other areas now. So do you have any last comments that they might want to have from your perspective as far as in your new role now on the payer side, what you see this impact on the work that is going on within the healthcare community?
Well, I think these conversations that we're having in the communities are going to be impactful. I think the different healthcare products, particularly products that have high deductibles and more consumer-directed health plans that patients and members, the community, are becoming much more price-sensitive. They're going to have a much higher demand for having this cost information available when they're making healthcare choices. And it's really unfair to put the doctors and other healthcare providers in that position when they don't have that information available to them. I think that's one of the next opportunities, is to really have a shared decision or an informed consent about additional testing and treatment. you have to have all those bits of information. I think we're getting there. I think there is more of a technological solution there, but there still is that cultural change that more is better and more expensive is better, or that we will continue to need to address. Otherwise, I don't think we're going to make the kind of directional impact that we really need, so that we really can make those other investments in our society and improve the health of the population, not just healthcare delivery.
Thanks, Howard, and I'm sure we'll be having many more conversations on many different formats, and we look forward to sort of being part of this journey as we move forward to addressing the triple aim with this incredibly important part of that. So thanks for all the information. It's very useful.
Well, thanks, Gary. It's been a pleasure to be back at ICSI this morning.
Pleasure myself. Thank you.
This brings us to the end of the webinar. For additional information about the webinar or work that ICSI is doing, please visit our website at www.ICSI.org. Thanks again for watching and have a good day.